Welcome to Case Study 12, Substance-Induced Psychosis, submitted by Shyamjit Jayadevan. Abstract. Substance-induced psychotic disorders are distinguished from primary psychotic disorders and can lead to severe mental illness such as schizophrenia and bipolar disorder. If proper risk assessments, pre-assessments, patient and provider education, healthcare policies, and standard of care are in place at healthcare organizations, substance-induced psychotic disorder patient can be treated and helped more effectively. This requires multidisciplinary and specialized intervention in order to develop better standard of care for these patients. Case presentation. Chief complaint: strange behavior. History of present illness. Mr. Wesley Brown, a 63-year-old businessman, was found down in the road by police and brought to the emergency room. The psychiatry service was consulted for management of psychotic behavior in the ER. The patient's family reported that the patient had exhibited an approximately 2-week history of strange behavior. According to his sister, Mr. Brown had been running around the kitchen with knives, sending paranoid emails about the justice system to his friends, showing his guns to the neighbors, seeing people in the walls, having paranoid thoughts that his wife was having an affair, and not sleeping. The patient's wife had reported him missing 3 days prior to admission. Notably, his car was found a few blocks away with a large box in its trunk containing numerous medications and patient's extensive gun collection. Allergies: no non-drug allergies. Current medication: metoprolol, emmencondin, and cyclobenzaprine. Past psychiatric history: none. Past medical history: coronary artery disease, back pain. Past surgical history: coronary artery bypass graft 5 years ago. Multiple spine surgeries. Family history: non-contributory. Social history: businessman by occupation. Smoking, alcohol, and drug history not available. Review of system. Patient denies headache, fever, chills. Denies any trouble seeing clearly, pain, itching, or draining of eyes. Denies nasal drainage, ear pain, cough, sore throat. Denies shortness of breath, chest pain, palpitations, nausea, vomiting, diarrhea, constipation, indigestion, and dysphagia. Denies extremity pain, joint pain, swelling, any change in gait, change in strength. Denies rash, itching, or any pain. Objective: physical exam. Patient is heavily sedated, pupil shows mydriasis, hyperactive bowel sounds, urinary retention, epistaxis, and depressed reflex. Mental status exam. Mr. Brown's mental status examination revealed waxing and waning alertness, an unkempt appearance, lack of cooperation with nursing and medical personnel, somewhat slurred speech, and signs of psychomotor retardation. His affect alternated between subdued, somnolent, and restless, agitated. He denied suicidal or homicidal ideation, but reported significant paranoid ideation that focused on his wife's suspected affair. His thought process was notably tangential. He denied both auditory and visual hallucinations. His judgment and insight were impaired. During his initial evaluation, the patient was noted to have a mini mental state examination score of 16 of 30 possible points. He lost 7 of 10 points for orientation, 3 for attention and calculation, 2 for recall, and 1 each for sentence writing and copying design. Assessment. Problem number 1, acute psychotic episode. Most likely diagnosis: substance-induced psychotic disorder. Patient has a long history of opioid use for his back pain. Changes in mood, speech, impaired memory, and attention is seen in patients with opioid intoxication, which can cause opioid-induced psychosis. His urine drug screen is also positive for benzodiazepine and tricyclics. Problem number 2, altered consciousness. Most likely diagnosis: substance intoxication delirium. Patient has waxing and waning alertness with significant changes in consciousness. Delirium could have developed during the emergency room stay, as incidence of delirium is high, as 80% in critically ill patients and up to 50% high in hospitalized patients. Differential diagnosis: brief psychotic episode. It's ruled out because of this patient's history of opioid use. Schizophrenia, ruled out because of acute onset with no prior history of any mental illness. Encephalopathy ruled out because of negative head CT, CSF, and normal blood work. Planning. Diagnostic test. CBC, BMP within normal limits. Blood alcohol negative. CSF from lumbar puncture within normal limits. Urine drug screen positive for benzodiazepine and tricyclics. CT head negative. CT cervical spine shows degeneration. EKG normal rate and rhythm. Treatment. Haldol 1 mg IM or IV BID PRN. Ativan 1 mg IM or IV BID PRN. Acute psychosis and agitation can be treated with antipsychotics and benzodiazepine. Antipsychotics has also shown to be effective in treating patients with delirium. Non-pharmacological treatment. The main focus of non-pharmacological treatment modality in any patient with suspected psychosis or delirium is patient safety. Discussion. Substance-induced psychotic disorder. Substance-induced psychosis is an acute psychotic episode that is caused by intoxication of a substance which results after the use of the substance is terminated. According to the Center of Substance Abuse Treatment, the criteria for diagnosis of substance-induced psychosis disorder are characterized by the following: prominent and persistent disturbance in mood, evidence of development of symptoms developed during the use of substance, disturbance not explained by mood disorder. Substance-induced psychotic disorders can be caused by opioids, alcohol, cannabis, phencyclidine, hallucinogens, sedatives, cocaine, amphetamine, other stimulants, disturbance not occurring during delirium, symptoms causing clinically significant distress. Substance intoxication delirium. Delirium is a disturbance in attention and awareness with an acute change from baseline happening over a short period of time. According to American Psychiatric Association, delirium is diagnosed when a patient shows change in attention, change in cognition, onset over a very short period of time, fluctuation in severity over the course of the day. Delirium can be caused by acute illness, infection, hyponatremia, surgery, substance use, hospital admission, medication. Implications to practice. Substance abuse treatment planning after discharge. Follow-up after the hospital stay. 32% of the patients with substance-induced psychosis later developed schizophrenia or bipolar disorder. Accurate and speedy diagnosis of delirium. Delirium in acute and subacute setting increase the morbidity and mortality in elderly patients. Preferences. That would be the end of this presentation. Thank you.